for you. It's been considered the gold standard for advanced osteoarthritis, but there are many, many people that have less than advanced arthritis but still have pain. So one of the things is that if you remove healthy bone and cartilage in someone that doesn't need a total knee, then you're again taking away healthy tissues. And so a partial knee replacement is if you only have one part of your knee that's affected and the other two compartments are relatively normal. So there's about 70,000 partial replacements done in the United States each year, and that's probably going to increase as surgeons become more aware of the fact that everybody doesn't need a total. That's kind of like the best tool that we've had for so long that, it's kind of like if the only tool you have is a hammer, then you're going to find a lot of nails to pound on. So one of the only tools that we had that everybody liked, and so we just put in total knees on people that probably could have a partial. And so it's very similar to the total, except it's just one part. So you've got the metal piece and the metal piece and the plastic liner. So here's the difference. Here's the partial, and here's the total where it goes all the way across. So something that's come about really in the past 5+ years is a orthopedic robots. Everybody's probably heard of like the Da Vinci robot that they use for obstetric or gynecological procedures, urological procedures, things like that. Well, now there is a orthopedic robot that allows us to do partial knee replacements, very specific and reproducible, with taking away a minimal amount of healthy bone and cartilage. And what that does is it kind of fills the gap for us. So you have early stages of knee pain that could probably be treated with an arthroscopy. And then you have the late stages where just everything is worn out in the joint and you need a total knee replacement. And then that middle stage, which is where a lot of people really are, is they might only have it on this part of their knee or that part of their knee, or maybe here and under the kneecap. And so there's all different options. You can have partial replacement here, a partial replacement here. You could have a partial just behind the kneecap. So there's lots of different options, and that's where a lot of patients really are. And so we evaluate your x-rays, and we talk to you about your symptoms, exactly what's happening, because that can give me a hint of whether you have some arthritis in another area of the knee. We take all that into account. So currently, it's thought that 43% of total knee patients may only have one area of arthritis. So 43% of patients that have had a total knee may have only had one area that really needed a replacement. Patellofemoral, that's the kneecap disease. Probably about 24% of patients just have disease behind the kneecap, making it difficult to stand from a seated position, going up and down stairs, and you feel a grinding sensation in the front of your knee. That may be the kneecap arthritis alone, and if the other areas look normal on x-ray and when I examine them you're not having any tenderness or pain in those areas, then you could be a candidate for just one. Then there's what's called bicompartmental. So if you have two of these areas, we can still do two partial replacements at the same time instead of just doing a total. The advantages of the partial, the main one is you get to keep your ACL. And so even though the total knee takes into account for the ACL and provides that stability, it's still metal and plastic, which doesn't feel as natural as your own ACL would. So that has some benefits in terms of how your knee feels. But you definitely should not be having bad pain.
Should I be feeling clicking?
Clicking is normal because, again, it's metal and plastic, and so those surfaces are moving. So hearing or feeling clicking is normal, but it shouldn't be painful clicking. So the way we do this is there's one additional step. We send you for a CAT scan of your knee. And the CAT scan is, the data from that CAT scan is imported into the robot's computer. And then very similar to what you saw a minute ago, except this is all done prior to me beginning the surgery. we can go in there with these different implants and we can look at different sizes. We can look if it needs to be this way or that way. I can turn this whole thing around 360 degrees on the screen. It's just a computer, and see it from all different angles in there. So it gives us really a bird's eye view of exactly what the replacement is going to look like in your knee, exactly how the bone needs to be prepared for the artificial pieces. And then what we do is we import all of this data and we save it in there, and then this is done like right before your surgery. It's not like days or weeks in advance. So then as we get you prepped and everything, the surgeon is still doing the surgery. So I'm still doing the surgery. I'm not off somewhere with there's not like a robot doing your surgery. It's a robotic arm. And so what that does is I basically see this on the screen, these green areas, and I go in with a device on the robot and we prepare those areas to shave away the damaged cartilage and bone, but just enough to what you need to have the implants put in there. And the way it works is if I try to go outside of the lines, the robot stops. I mean, it will not let you go beyond what you need to do. So it's basically like coloring.
So in your pre-plans, are you using a particular shape in the knee?
Yes.
Has that been inputted into that so that it's recreating this exact space it needs for that particular piece?
Yes. Yep.
So you're not using the 3D imaging to create the actual piece, you're just accommodating the pieces that you have at your table?
Correct. Correct. So this is kind of what it is. We're in there kind of sculpting away this bone, and I can see everything on a screen, but if I go outside the lines, it won't let me. And this is kind of what the implant looks like.
And that's a partial.
That's a partial. Yep. Here's a little animation. It's kind of brief, but so that's the robotic arm right here. This is the computer. And this arm weighs like 150 pounds, but when you use it, it just kind of glides until it stops you. So there's the CAT scan information that's put in there. So again, we were talking about that gap balancing the gaps between the knees and when it's straight and flexed. So we look at all that on the computer, and then we double check it when we're in there. So this is the little device that we use that kind of prepares everything, and I can see it on the screen in green. So I know that I've taken just the right amount. We do that on both surfaces. Doesn't it look like fun?
Anybody could do it.
Anybody could do it.
It's too scary to me.
So that's basically it. Currently, these implants are cemented in place. They don't have them yet with enough stability. You asked about the stability of the knee and how quickly it grows in there. So they don't have the design quite where it's ready for the press fit, but that's going to be coming.
How soon?
How soon? You don't want the cement? I don't know. That's
Pretty soon.
oh.
We just turned.
It has been approved,
It has
FDA
been
approval,
approved.
but it's not ready for use yet. So it is,
It has been approved, yeah, we just heard yesterday.
So you think within a year? Should be. And we were dealing with the FDA, so.
Because I was told that the cement can like crack or come undone or something like that.
Right, there is a theoretical risk of that, cracking or coming undone, but I would tell you that the vast majority of orthopedic surgeons still use cement.
Yeah.
I mean,
That's the standard.
that is still the gold standard, is to use cement. So I'm not trying to tell you that, oh, that's an awful way of doing it. That is the gold standard. I think back in the day, we used to do press fits only for people that were younger. So we're like, oh, well, they're younger, they're going to need their knee longer, so we'll do the press fit. Well, young is all arbitrary at this point. I mean, people live forever. So, 70 is young. If you're gonna need that knee till you're 100. So, I mean, it's 30 years you got to live with it. So, anyway, so that's why that was one of the big reasons where I switched to the press fit, because I was not good at predicting how long someone was going to need their knee. That was a different specialty, a higher specialty that I have not been good at. Although there's always jokes about surgeons having a God complex, but you know. So yeah, some of the potential benefits of this Makoplasty are improved surgical outcomes, less implant wear and loosening because we've got the anatomy recreated perfectly for you. It's bone sparing and tissue sparing. We're able to preserve the ACL ligament and the PCL so it feels more natural to you.
Is it likely that the other compartment will need to be replaced?
Good question. Right, so he asked, would the other compartment need to be replaced in the future? It depends. So if your other compartment continues, you know, just like with a normal knee, if it wore down over time, then yes, that's possible. And that's where we have to use a judgment. I mean, if it looks completely normal or just a little scuffed up, I think you can still have a partial. But if you're already having some arthritis in the other compartment, then I would, you know, have the total. And we usually know that pretty well in advance of surgery. But in case there was a surprise, that could be done. The other thing is people ask, well, if you have a partial and later you wear out other parts, does that make the knee replacement more difficult? And I think particularly with this being so limited in terms of how much bone is removed, it's really like having what we call a primary knee replacement instead of a revision. And a primary is different than a revision because it's got, it's just designed differently. So you would still be able to probably have a primary, depending on the amount of bone loss and things that you have.